Here we have 18-year-old with history of left-sided neck swelling. So what we have got here is a well-defined ovoid-shaped heterogeneously isoechoic nodule, and on Doppler signal there is predominantly peripheral vascularity and also there is some central vascularity. So based on these findings, features are characterized as U3 nodule based on the British Thyroid Association classification. In our institution, again, we divide the U3 nodules which are less than 15 millimeter in long axis and more than 15 millimeter in long axis. If there are more than 15 millimeter in long axis, only then we do FNA. Here the nodule is more than 15 millimeter in long axis, and then hence this patient, although in on the non-Doppler features are suggestive of U2 because of the some vascularity in the center, it is upgraded from U2 to U3, and the patient will have ultrasound guided FNA. Having said that, in my clinical experience, I have come across with many U2 appearing nodules with some central vascularity, and all of them have come back as benign nodules on cytology. Hence, I really doubt the importance of these kind of patchy Doppler signal, which is non-continuous from periphery to center, to grade them as U3. I think further studies are needed for further subclassifying the type of vascularity when we see on thyroid ultrasound in the next edition of British Thyroid Association classification. Although I don't have a data to substantiate, what I have seen is in patients with few small dot-like central vascularity with significant peripheral vascularity, all of them have come back as U2 on cytology. In summary, this patient is characterized as U3, although the non-Doppler findings are suggestive of U2 because of the British Thyroid Association grading system. But I'm really asking here for further studies to further subclassify the vascularity so that many of these lesions can be downgraded to U2 and FNA can be avoided.